You can get started.
Thank you all for joining. Dr. Mehta, please get started.
Thank you, Jessica. Welcome everybody to Spine Time, your free webinar with back and neck experts. As you may recall, this was started during the early days of COVID and has been such a fun and fruitful exercise for us that we continue this now for 2.5 years straight. This is your bi-weekly presentation on various topics regarding spine and back and neck pain issues. And today we're going to talk about something very, very new. I am your host, Dr. Neil Mehta. I'm the Director of Pain Management. We've probably met before for many of you that have seen me on Spine Time before. Just a couple reminders. There is a meeting chat that allows you to ask questions along the way. This is a more dialogue format between myself and the other participants on the program, and we will field questions as they come. Furthermore, this is being recorded and will be accessible on our YouTube channel to be able to view at a future date and also be able to see past Spine Time programs. We are part of the Weill Cornell Medicine Center for Comprehensive Spine Care on 59th and 2nd, where we have spine surgery, pain management, rehabilitation medicine, and other disciplines that are involved in spine care. And today, I'm joined by two of my friends and colleagues. First, on the left is Dr. Daniel Pak. He is an assistant professor of clinical anesthesiology and one of our attendings in the pain management division of the Department of Anesthesiology. He also serves as the co-director for the Pain Management Fellowship. And on our right is Dr. Gail Salama. She's an assistant professor of clinical radiology and the director of spine imaging here at Weill Cornell Medicine and NewYork-Presbyterian Hospital. So welcome, Dr. Pak and Dr. Salama. Thank you for joining me today. We're going to start with what is a basovertebral nerve, and I think this is going to be very new for most of our viewers. Dr. Salama, maybe you can take a moment, just walk us through what are we looking at here?
Sure, Dr. Mehta, thank you for the introduction and thank you for inviting me to another Spine Time. So today we're specifically talking about the basovertebral nerve and more specifically an intervention that we can offer to patients when we believe or have reason to think that pain is coming from an area where the basovertebral nerve gives that pain sensation. So this is a little drawing I created to help us understand exactly the part of the anatomy that we're looking at. So in the background, you have the vertebral body. That's that beige structure. And this is what a lumbar or a lower spine vertebral body looks like. The yellow structures, both the little dots within the center of the vertebral body, exactly, and the yellow lines that are coming out on the right side of the image are all different types of nerves that originate from the spinal cord and branch out of the spinal canal. Specifically, that yellow line that curves around over the vertebral body where there's a blue arrow is what's called the basovertebral nerve. And that is a nerve that receives pain information from a portion of the vertebral body called the end plate, or the portion of the bone that's right next to the disc, which separates two vertebral body or two backbones. And studies and dissections have shown that this is the nerve that provides a lot of the pain sensation when patients feel pain coming from the end plate or where the bone meets the disc. And that's what we call vertebrogenic pain. And this is the nerve that is one of the inputs that gives us that pain sensation.
And if we take a step back, just for some that may not have had the luxury of viewing our prior Spine Times on spinal anatomy, what is the purpose of the vertebral body and how common is this issue?
So the vertebral body is the bone that we have many vertebral bodies, and they're the bones that comprise up our spinal canal. And we think that this issue where we're having pain come from the end plates is actually extremely common and more common than we previously thought, based on some of the recent studies that looked at what happens when you get rid of this nerve or the sensation coming from this nerve, and how many people respond to that. And if we appropriately evaluate a patient and decide that the end plate is a possibility of a pain generator, then eliminating this nerve can potentially help in, greater than 80% of patients. So it's probably a very common pain generator, and it was previously underestimated. I don't think we previously knew how many patients were truly affected by pain coming from this particular nerve in this particular location. And we're learning as the studies go on that probably more patients than we originally thought.
Okay. And what does the red represent that you've shown here?
So the red is the trajectory or the course that our probe or the tool that we use to get to the nerve to potentially burn it or destroy it, that's the course that our tool would take through the vertebral body, starting in the back where those sort of pokey parts of the bone are. And we would go through the bone and curve a little bit towards the center where it meets the yellow. And that's the course that our tools would take in a minimally invasive way to be able to burn or destroy a specific area of the basivertebral nerve.
Got it. Okay. So I know that you were kind enough to show us what an MRI would look like. Walk us through what we're looking at here.
Sure. So these are 4 separate pictures of someone's lower spine or lumbar spine, as if you're looking at them from the side. And specifically, we're going to look at the areas where the blue arrows are, and we're going to compare those to some of the other areas above that. And in the first set of pictures, the first 2 pictures on the left, we're specifically looking at the part of the vertebral body called the end plates, and that's next to the disc. So the blue is pointing to the end plate, and the disc is right next to it. And in this example, we're showing swelling or edema or fluid inside of the bone marrow, and that's abnormal. And that's what one type of finding that we can see on MR that would suggest that maybe somebody's having pain from their vertebral body or end plate. And then that's one type, and that's considered type 1 when we refer to the words modic type change. And then the 2 pictures on the right side are referring to modic type 2 change or fatty changes. And that's when the bone marrow changes its composition and it has more fatty composition than we would normally expect. And the studies show that both type 1, which is swelling or edema, or type 2, which is fatty change, are highly associated with pain generation for patients.
Got it. I know we're getting a few questions about the actual technique, but why don't we spend a little more time just talking about how do we identify patients and so forth here. So before we get to the treatments parts, Dan, maybe walk us through what is a patient generally going to feel when it starts to turn the wheels in your head about this is a good option?
Yeah, so, the first thing is really the diagnostic portion, which is figuring out, is the back pain actually coming from the vertebral bodies, like Dr. Salama just said. In our world, we see a lot of patients with chronic low back pain. There's a lot of different types of sources from that. So if you've seen us in the pain clinic, we will always try to figure out, in addition with imaging, doing physical exam maneuvers to be able to figure out, is this actually coming from the vertebral body? So, there's a lot of other sources for pain, like the discs themselves, the muscles of the back, the SI joints, et cetera, the facet joints. So when someone comes in and they say, well, look, I have really bad back pain and it seems to be more midline, so not off to the side, but more midline, and they don't have radicular symptoms, meaning pain that goes down the legs, then we start thinking about this. In addition to that, a lot of our patients who have vertebrogenic pain will say that sitting for long periods of time or standing for long periods of time really causes a lot of pain, and then lying down makes it feel better. That in conjunction with flexion movements, so flexing forward oftentimes will exacerbate the pain. If we take that in conjunction with the MRI findings, then we start thinking, okay, maybe this is actually coming from the vertebral bodies.
Got it.
But in terms of, who do we think about for this procedure itself? I mean, I think I saw a question about who are the ideal candidates. And I think from our standpoint, most of our patients have kind of already undergone through more conservative therapies, right? So you see them on the slide here. When I write analgesics, these are pain medications. So most things I think that people are familiar with, non-steroidal anti-inflammatories, Tylenol, among other things. They might have even tried nerve pain medications. A lot of our folks have already tried that. We will generally try to encourage people to do things like physical therapy, so core strengthening, although admittedly, that doesn't necessarily address the underlying issue, but certainly if you are looking for a less invasive option, then physical therapy is certainly among those treatments that are available. And for a lot of our patients, they've already gone through kind of the traditional injections. So they might have already had facet injections. They may have already had SI joint injections, maybe an epidural steroid injection, because people are trying to rule out some of the other things that I talked about. And so when those have all kind of not really provided adequate relief, then I think we start thinking, okay, maybe this procedure is a good next avenue.
So it doesn't sound like this is going to be the first thing that you would offer a patient. But maybe talk about, like, what is the patient going to tell you in terms of different ways that they experience pain? Is it mainly when they stand? Is it mainly when they sit? I think I've read that some of these folks say that bending forward actually makes it worse, as opposed to some of the spinal stenosis conditions, which often get better when they bend forward.
Right.
What have you seen as characteristics?
Yeah, just like you said, often our patients will say sitting for long periods of time will exacerbate the pain, or even standing for long periods of time. I think one important component is certainly the flexion component, as Dr. Mehta said. So patients with spinal stenosis, for example, will oftentimes say bending forward makes it better, right? But for our patients with vertebrogenic pain, oftentimes bending forward causes worsening of that pain. Again, the pain tends to be more midline, so straight down the middle, as opposed to off to the side. So patients with SI joint mediated pain will oftentimes say it's more kind of buttock off to the side. And so those are all clues that we look at in terms of figuring out, okay, is this actually from the vertebral bodies versus another area? Although admittedly, there is a lot of overlap in terms of symptomatology. So
to add to who are candidates, I think we also use specific criteria. So while, the initial evaluator, pain management doctor, needs to understand, as you were saying, Dr. Pack, about the patient's history, their physical exam, things that provoke the pain. We also have certain criteria that patients have to meet to qualify them for the procedure. So it's at least 6 months of conservative therapy, many of which Dr. Pack has beautifully delineated. And the other thing is the procedure is only so far approved for certain spinal levels. So it has to be involving the L3, L4, L5, or S1 vertebral bodies. So it's only approved for a specific area of the lumbar spine. Obviously, that may change over time with more data and more experience, but certainly that's a part of the inclusion criteria. So if you have these modic type or end plate changes elsewhere in the spine, unfortunately, basivertebral nerve ablation isn't a choice at the current time.
And what about those that have had prior spine surgeries, disc surgery came up as a question, laminectomies? What is the role there, or does it contraindicate it in those patients?
I don't think there's an absolute contraindication, meaning, just the history alone doesn't exclude someone. Obviously, there has to be a safe entry point. So, hardware may exclude somebody depending on where someone's hardware is. But if our access still exists and they meet the other criteria, they could still be a candidate, especially if they've had a failed surgery that may not have helped their pain that they presented with. This may be an additional option for them.
Sure. Dr. Pak, there was a question in the chat about someone that's had radiofrequency ablation twice. Mm-hmm. Is this the same procedure? How does this differ to, I would imagine, facet joint radiofrequency? Right. So if someone has, most likely if people have had multiple radiofrequency ablations, it is most likely in reference to the facet joints, as Dr. Mehta said. So the facet joints are also a common source of back pain.
Those are the joints of, most frequently we do this for the lumbar spine. So the lumbar spine that allows you to flex and bend back or forwards and backwards. Oftentimes those patients have exacerbation of pain with an extension movement. This is a different procedure, and it's addressing a different etiology for their pain. So that is really it's a similar type of, I think, underlying treatment, which is that it's a radiofrequency ablation. However, when you're doing it for the facet joints, it's at the level of the medial branches, which is a different nerve altogether. And this is entirely different. This is really going towards the vertebral body. So same type of technology. In this particular case, if you kind of get into the nitty gritty, what we do is we essentially take a lesion of 85 degrees for this particular procedure, and we do it for a longer period of time. So typically for a regular lumbar radiofrequency ablation, most people will do it for about a minute and a half. In this particular case, it's closer to around 15 minutes.
And again, more questions coming about the technique. Is there a diagnostic value to this? Is there a diagnostic injection, I should say?
Yeah, so there is not. I think I saw in the question, is there like a lidocaine injection that you can do? And not really. In a lot of ways, some of the diagnostics that we have from an intervention standpoint is, in a lot of ways, every single time we do different types of procedures, it helps to rule in and rule out different etiologies for their pain. So a lot of our patients do have pain from multiple sources. So it would not be uncommon for patients to have low back pain that comes from many places. And so let's say if a radiofrequency ablation for the lumbar spine, if an SI joint injection, if those things are all done and they're not effective, and again, we have a high index of suspicion that it's from the vertebral bodies based on everything we've talked about, then oftentimes that is enough evidence for us to go and proceed with this procedure.
And Dr. Salama, what's the duration of this? I mean, is this something that is repeated from time to time? Is this a once and done procedure? What's your take on this?
So the studies show that it's a long-lasting procedure and patients really don't need repeat procedures. Given that it's a new procedure, obviously that data is limited, but they do have data up until 5-6 years now. And that it's really showing to be long-lasting, where it's a different response than sometimes radiofrequency ablation and things that really need repeated ablation. This is a different scenario, and that it's usually a one and done situation.
And to both of you, a couple of questions came in about potential for complication. Is there a chance of vertebral fracture, and what are we losing by ablating the basal vertebral nerve? What was the original purpose there?
Yeah, so complications, certainly we always review these with patients beforehand. There's complications inherent in the procedure itself. So obviously getting into the spine, risk of bleeding, infection, things like spinal cord or nerve injury are exceedingly rare. We do all of this under image guidance. So sometimes some of our interventional radiology folks and Dr. Salamo, sometimes we'll use like a CT guided approach. Some people will use fluoroscopy, which is X-ray if you're a pain physician. So those things are all there to mitigate the risks of the things that I just talked about. There is kind of careful patient selection that we use, and we do have indications and contraindications for people we think this works best for. And so, those things are all reviewed with the patient beforehand.
And I'm sorry, go ahead, Dr. Salama.
Yeah, somebody specifically asked about weakening of the vertebral body or fracture. It is a extremely rare complication with this procedure. And there's only, I believe in the trials, only one patient out of hundreds of patients had a mild fracture, and that patient had loss of the normal bone mineralization or osteopenia or osteoporosis. So there is that remote risk of fracture, but it's not actually from the burning of the nerve itself. Simply by putting a tool into the bone is what in theory causes a fracture. The basivertebral nerve, we know gives sensation to part of the disc and part of the vertebral body, but there's no noticeable deficit other than a decrease of pain after the procedure in terms of what's the risk in actually burning the nerve itself. What are you going to lose? Hopefully it's the loss of the pain sensation, which is in this case is what you want, is a good thing.
And one thing I will also make note of is, Dr. Mehta has shown some pictures of how the procedure is actually done. And, I think when we say radiofrequency ablation and burning of nerves, that can sound very aggressive and very intimidating. And, again, it's a controlled lesion. What we actually do is called a bipolar lesion, right? So there are, if you can see the picture here, once we actually advance the instrument to where we need it to be, which is a very precise location. Again, we do this with image guidance. The lesion is over a very kind of small distance, and it's very exact in terms of location, which prevents, from it going to places where we don't want it to be. So I think a lot of people will ask, well, you're burning nerves. That sounds pretty scary. And what I will say, it's a controlled small lesion that we're actually doing.
And if you've had the procedure done and you ever get future spine imaging, it's actually really important to note either on your radiology paperwork or have your referring physician who's ordering you your repeat imaging put into the history, because what happens is we can actually see the intentional lesion that is created in your lumbar spine, and it can be confusing to a radiologist who may not know that you've had that procedure if they're working outside of the electronic medical record that you're using for your referring physician. So a radiologist may not know that that's an intentional lesion and may question whether something else is, going on that needs follow-up. But if they know that you had this procedure, it's really important for them, because they could say, okay, this is supposed to be there. This is the expected post-procedure finding and everything looks good, rather than telling you that something else might be going on and you need follow-up. So really important, communicate with the radiologist, communicate with the referring to put it on the referrals for future imaging. Super helpful to the radiologist.
So let's talk a little bit more about the technique. You mentioned a few things about how many levels may be involved. Do you tend to do more than one level at a time? And then what's the anesthesia and recovery like?
Sure. So I think the levels Dr. Salama had already touched upon. So there are only certain levels where where it's indicated where we can do this procedure. So L3 to S1. There are some cases where people get multiple levels. And again, that's depending on kind of the criteria and what we see on the MRI. So certainly there are cases where more than one level can be done, because oftentimes for a lot of folks, it's not just a single level issue. The question of anesthesia, I think, is a great one. And I think it depends on provider to provider, but for most of us, it's done under some form of anesthesia. Usually it's more of what we call a MAC anesthesia, or like a deep sedation. So it's not your traditional general anesthesia. It's more like a twilight. So it's very similar to what you would get for example, colonoscopy. So there's some advantages to that. It's a deeper sedation. You may hear voices, but generally you're not really aware of what's going on in the recovery. In the recovery area is a lot faster, and you avoid a lot of the issues associated with general anesthesia, like nausea, vomiting, confusion, et cetera. And you don't have to stay in the recovery area for as long. So from an anesthesia standpoint, it's actually not heavily involved.
And what's the recovery like?
Yeah, so I think for most of our folks, what we tell them is, to take it easy for the next several days. But to be quite honest with you, we don't have a lot of exact limitations. The procedure itself, if you get into the nitty gritty, it's really, depending on how many lesions you do, you're talking about maybe a couple 1 centimeter incisions. Most of us don't even put sutures over the area. And despite the fact that it sounds aggressive to be able to put an instrument through the bone, it's actually not all that painful for a lot of people. So, I think the recovery period, you might feel sore for a few days, but I think beyond that, it's just really kind of elevating your level of activity as tolerated.
And when would you expect to start to see the benefit after the ablation? Maybe Dr. Salama, you want to answer that, or whoever wants to take it.
I think it's pretty quick. Some patients have a temporary increase in pain just from having a procedure done on their back. However, often patients will start seeing results within a few weeks, and certainly by 3 months. But within a few weeks after sort of the post-procedure discomfort goes away.
And what sort of percentage of improvement did they see in the study, and how do you counsel your patients about it?
Sure. So about a third of patients with Modic type 1 or Modic type 2 changes on their MRI and appropriate, selection based on their symptoms and their history, a third of patients had 100% pain relief, which is pretty remarkable for any pain patient. We don't often expect no matter what we do, to get 100% relief. And then another 40 to 50% of patients had 75% of relief. So based on the quick math, it's close to 70 to 80% of patients will presumably, if selected correctly, have significant greater than 75% pain relief.
Got it. So a few questions talking about specifics that might be contraindications. For my longstanding patient and friend, Rita, she has a nasty scoliosis curve. Scoliosis, something that's doable in this procedure?
So scoliosis in and by itself is not a contraindication. We will always look at the imaging beforehand. And so really, when we're looking at the imaging, we're looking at a few things. First of all, not only the modic changes and the things that Dr. Salama mentioned, but also, for example, what is feasible and from an access standpoint. So scoliosis in and by itself is not a contraindication. I think I saw some other questions about osteoporosis, for example. That also in and by itself is not a contraindication, although for people who have a history of vertebral compression fractures or they're on medications for osteoporosis, those are a conversation that you have with the provider.
What about immunocompromised patients?
So being immunocompromised in and by itself is not a contraindication. Being immunocompromised certainly is always a higher risk for infection. So again, those are things that you have to keep in mind. But again, this procedure, fortunately, is not a very invasive one.
And I think, Robin, we answered your question about this is outpatient and that you do go home the same day after light anesthesia. Here, the next image is, I think, Dr. Pak, these are your slides. Just kind of talk to us about what's happening here.
Yeah. So these are just what we would see as the practitioner when we're actually doing the procedure itself. We keep on talking about access point. How do you get into the bone? What we're looking at here is specifically something called the pedicle to get access into the vertebral body. So that's what this is showing kind of step by step. What you see here is a kind of an access cannula, and then what you see extending into the vertebral body, which looks like almost like a probe. That's what actually conducts the lesioning. And so again, this is really just to demonstrate kind of the things that we're looking at when we're doing this. And again, these are instruments that are pretty small. So that's the reason why we can do this as an outpatient, why we can do this under really kind of minimal sedation, and then also have a kind of a quick recovery period afterwards.
Sure.
Somebody asked if being immunocompromised is a contraindication. So being immunocompromised in and of itself is not a contraindication. Having any sort of infection, whether it's in the spine or anywhere else, is a contraindication. So one would have to be certain that no ongoing or chronic infections are present, and then potentially you would be a candidate.
Okay. In order of the questions coming in, I think someone asked about prior fusions, and I know, Dr. Salama, you mentioned that as long as the hardware doesn't block the access point, it shouldn't be a contraindication. Can it be done in the coccyx area?
So so it's not really for the coccyx, although the S1 is certainly lower down, but although radio frequency ablation, it's not specifically for the coccyx, correct?
Yeah. And then who does the procedure? I know you two are doing it. I'm on my way to go get trained. So there's a variety of folks here, and certainly Youssef and anybody else interested. I will, in fact, let me give you this phone number here. All of us have some basic understanding of the procedure and can get you to the right person, as Dr. Salama and Dr. Pak, to potentially do this. Ms. Fisher wanted to kind of go over the stats again. Maybe Dr. Salama, you could walk her through that.
Sure. So the studies that are out showed that approximately a third of patients, if selected appropriately, had 100% pain relief. And then about 40 to 50% of patients had at least 75% of pain relief. So we're talking about 75 to 80% of patients will have at least 75% reduction in their pain, as determined by pain scores that your physician can use to monitor your pain levels.
And then
Yeah, it really, for a pain management procedure, that those are unbelievable statistics. We hope and pray for procedures that have those kind of responses. So certainly a great option if selected appropriately for the patient.
Yeah, and I think that's, as our audience can certainly appreciate, that the hardest part is interpreting the nature of the pain and diagnosis to then send you to the right treatment. Okay, a couple of rapid fire questions as we wind down. Are antibiotics given?
Antibiotics are not given post-procedure. I can see the question. Pre-procedure, that will be.
Will this help neuropathy?
It is not designed for typical neuropathy.
Got it. And finally, will the procedure work for arthritis post-discectomy surgery?
So I guess it's really not specifically for arthritis. This is more, again, when people think about arthritis, we're oftentimes thinking about other components of the spine. It can be a degenerative process that causes end plate changes in the vertebral body. But again, it's based on the criteria that we talked about from before.
And actually, I forgot to bring this question up, which I thought was interesting. Scott earlier asked about, I guess he maybe got sparked in interest on that fatty infiltration of the bone that you were mentioning, Dr. Salama. And he said, is this effective for epidural lipomatosis, secondary to long-time steroid usage?
Yeah, so epidural lipomatosis is a separate disease entity or separate condition of the spine. And the fatty changes that occur in the vertebral body or end plates is a completely separate process from fatty changes in the epidural space. So unfortunately, this would not be a procedure to address that issue.
Sure. And I think a good sort of conclusion is to finally go back to our previous slide about what are the things that we should think about first and kind of rule out before going to this procedure?
Yeah, the things that would be ruled out should be the other sources of back pain that we commonly see. And so you don't want to miss degenerative disc disease, certainly. So patients with lumbar radiculopathy or shooting pains down the legs want to make sure that is being ruled out, right? So that, in addition to a lot of the other sources of back pain, so from the sacroiliac joints, the lumbar facet joints, the muscles of the back, because again, this procedure would not really address those things. So we would want to rule out those types of things before going to BVN. In addition to, if you do have vertebrogenic pain, the criteria is, again, 6 months of conservative therapy that hasn't really worked out. So all the things that you see on this slide here.
Fantastic. You guys are awesome. Thank you so much for taking the time to walk us through this really, really exciting new procedure. As always, for our audience, we hope that you join us for our next talk in 2 weeks. And I wish I could recall what the topic was offhand, but I don't. But you can always find us on the YouTube channel. And, obviously you can always come and see us in the Spine Center for an appointment to discuss this treatment or anything else that may be coming to mind. So hope that it's been informative for you, and we will see you next time. Thanks very much. Have a good night.